We are going to start again to take a moment to recognize the San Diego Pain Summit is held upon a land that carries the footsteps of millennia of the Kumeyaay people. They are people whose traditional lifeways intertwine with the worldview of earth and sky in a community of living beings. This land is part of a relationship that has nourished, healed, protected, and embraced the Kumeyaay people. In honor of this legacy from the Kumeyaay people, who were forcibly removed from their ancestral lands, please consider a donation to the American Indian College Fund or the Kumeyaay Guano Land Conservancy. These links can be found in the footer of the DPS website. Again, remember you only have until March 10th to purchase the recordings of all of the wonderful talks from the entire conference. And those are the end of my announcements. So now I will introduce the amazing Tasha Stanton, Associate, I love the, yes. Associate Professor Tasha Stanton is the Osteoarthritis Research Theme Lead for Impact in Health at the University of South Australia, Adelaide. She is a clinical pain neuroscientist with original training as a physiotherapist. She has a specific interest in chronic pain, pain science education, cortical body representation, and new technologies such as virtual and mediated reality. So please welcome Tasha.
Love it. Feels so welcome. Hello, everyone. Good morning. Who else discovered that margaritas are real strong here? Anyways, I love this. You got to have them for breakfast. Thank you so much for the invitation from Rajam to speak here. This is honestly one of my favorite conferences. So I speak here today with a lot of joy in my heart, but a little bit grief, because I think when beautiful things occur, it's always really sad and hard to see that sometimes they don't go forever. But I feel, so honored to be here as part of this conference and to share some of the work that we're doing. And hello to everyone online. We know you're there. We love you. Thank you for joining. So today I'm going to talk about how we might be able to push the boundaries of perception for chronic pain. And if you've seen any of my work or know some of the things that I do, you'll know that I am intrigued by how we experience what we experience and why we experience what we experience. Because when you start to think about it, I think possibly because the way that I grew up, everything was really black and white in terms of we know that this occurs for this reason. And actually then when you start to understand that things are way more complex than we think, the world becomes way more interesting. And I think I've always been blown away by the fact that every single thing that we experience is influenced by so many things that we aren't even aware of, and they can profoundly shape what we experience. So I'm going to show you a picture. What you're going to see, looks like kind of a black hole in the middle of the screen. I just want you to notice what happens when you look at it. If you close your eyes and then look right to the middle of it, sometimes you'll get that a bit stronger. And what this is one of a newer illusion that's been created, that it has kind of a smear or a bit of a shadow gradient around that central black hole. And what it does is it evokes actually an impression of optic flow. So it's as if you are headed into either a black hole or a tunnel. And what's really interesting, I feel like, from these things is that, of course, this is a static image. Now, if you have any trouble seeing this, bring it up on your computer. Just look up central black hole, and I swear nothing bad will happen. A more common illusion that is definitely easy to see is this illusion of a rotating mask, which of course, it's very popular, it's very well known because the mask itself appears to change direction rotation, but it actually doesn't. But your brain has learned that faces curve outwards, so it would rather have you see that mask change direction rotation than have you see a very weird inward curving face. You can see that outside with the Einstein face. But interesting part to me, though, is that even when we know about this, we can't unsee it. Those behind-the-scene processes are strong. And why I think I get so interested in these different aspects of perception is it appears that it extends to pain. This is an oldie but a goodie, friends. I'm sure you've heard it lots of times, but if you touch people on the skin with an ice-cold probe, it matters the color of light that you shine on the skin, whether it's red or blue. The exact same probe hurts significantly more merely by shining a red light on the skin. And when people are asked to describe what they feel, they get it entirely wrong. If you shine a red light first, they describe that probe as painfully hot. Why? We think we've learned, right? That red equals hot, red equals dangerous, and blue typically equals cold and maybe even calming. So there's inherent meaning in things that we experience every day that profoundly shape what we experience. And I've always been really interested in taking some of these findings that we see in healthy volunteers, people without pain, and saying, do we see any translation to people that do have pain? And so, as an example, we looked at this aspect, worked with dental specialists out of Western Australia, working with people who had burning mouth syndrome, so burning pain in the tongue, lips, oral mucosa. And we use a technology that I'm going to talk a fair bit about in this talk called mediated reality, where it changes real-time video. And all we did in this case is we showed them they could see their own tongue, but we turned it blue. We made them a Smurf. We color inverted it. And we took a look to see what happens to what they feel. And what we found is that merely shifting that color of the tongue was sufficient to reduce the burning pain in their tongue. And what was intriguing of this is that this is often a population that not very many things work. So to see something that responded quite quickly and for them from self-report was quite potent was a really intriguing thing and suggests that actually some of these behind-the-scene processes might still be kicking around and working in people with pain. So all of this together really suggests that what we experience is not just a simple readout of sensory information coming in. Instead, what happens is incoming information, there's a lot going on. It undergoes filtering, integrating, prioritizing, modulation before it ever enters our conscious awareness and we experience something. And I think what's cool about this is it lets us know, first of all, that there is a lot going on behind the scenes, but also it means that each of us create our own individualized perception. And isn't that relevant when we're thinking about the individualized people in front of us that we're trying to help? So one of the ways that I feel that we can look to push the boundaries of perception is by looking into processes of sensory modulation. And so this is really just referring to the ability of sensory input to change or modulate another sensory source. And in fact, we all have these inbuilt processes that link sensory information about our body. It's how we navigate the world. But all of these different processes, while they interlink, they can be shifted and influence our perceptions. So there's well-known links between vision of your own body and the pain that you feel. So this is some older work now, but this is back Matthew Longo's work in 2009, looking at what happens when you see your own skin. And what his work showed is that if you're zapping people with a laser, merely having vision of your own skin makes an identical laser hurt less than when you're viewing, let's say, an object in the same spatial orientation. And when they neuroimage the brain at the same time, what they're seeing is that you're getting different connections. The area of the brain that typically lights up when you view your own skin, that is greater functional connection to areas that typically light up when we feel pain. And so we're seeing changes in the way that we're processing sensory information merely by the fact that we're viewing our own skin. And what I love about this, though, is that we're way more complex than that as well. It's not just viewing our own body. It matters the size that we perceive our own body. So if we take people and you give them a hot burning probe on the hand and you change the size of the viewed hand, that matters to the pain experience. So when they see their hand as smaller, actually people have a lower pain threshold, so they're more sensitive. If they merely see their hand as bigger, they have a higher pain threshold, they're less sensitive. So we have this ability, potentially, these behind-the-scene processes that are changing the pain intensity that we feel. And so what I've been intrigued by, and stuff that I've done for a little while, is wondering, can we hijack some of these behind-the-scene processes and use them for good? Are they potentially still working in people with chronic pain? And can we use them in our interventions? And this is where I think I've really, come into work in painful knee osteoarthritis, primarily because I kind of love when you have a condition that's always considered just to be one thing. We know what's going on. This is what it is. And it's delicious, isn't it? As soon as you realize we don't. So in this condition, what we've been looking at is this mediated reality where we're changing real-time video. And so we're taking people with painful knee osteoarthritis and doing body morph illusions, where we change how their body looks and feels to them. And this is an example of a stretch illusion, and we call this a non-affine illusion, meaning that we're not changing the entire size of the body, but we're actually focusing the illusion exactly on that painful body part. Now I'm going to show you what this illusion looks like in real time. I want you to imagine you've got your legs straight out in front of you. You're looking down at the top of your kneecap. But what you'll see is that it begins to elongate in real time. And we pull on the calf muscle towards the foot. So your brain is getting this information from vision and from touch that the limb is truly growing or changing in size. And what's weird is, of course, it's not actually changing in size. Consciously, you're aware of this. But it feels like it is. It's a very potent feeling. And so we took people with painful knee osteoarthritis and we wondered, if we are using this illusion on their painful knee joint, what might happen to the pain they feel? So we had people come in, we didn't tell them about what the real illusion was, we didn't tell them much at all, actually, and then had various different conditions all in a randomized order and looked to see what happened to their pain. And this is what we found. Size matters, man. What we found is that when we do this real illusion, we get a significant reduction in their pain intensity. But importantly, it does not occur if we just pull on the leg. It does not occur if we just visually change the size of the leg, suggesting that the effects that we see are specific to changing how they're viewing this body part. And to me, this suggests, well, this is kind of cool. Maybe some of these processes that we see occurring in healthy volunteers without pain, maybe they're still intact and potentially working in people with chronic pain, and we can use them for good. And in some of our more recent work, you always got to push the boundaries, don't you? That's what makes things interesting. So we've been interested to see how far can we push this? How much is believable? What can you take on? And so we've been exploring what we call the bodybuilder illusion, giving people that ridiculous strong image of a back. And what we did in this study is we were wondering, to what extent can we alter more complex perceptions? And what information do we take from seeing our own body in different forms? And so in this case, we had people with back pain who were doing a lifting task, and they saw their back under 3 different conditions, either a no illusion, a bigger condition where they just had wider shoulders, or a stronger condition where we overlaid this ridiculous image of a muscled back. Now, what we did find is that turns out there are limits. Lots of people couldn't embody this. This was too weird. But what we did see is that when people had this is just case study data, but people that had quite impaired back perception, so they had trouble knowing where their back was located in space, difficulty identifying where they were touched on their back, for them, that wasn't a stretch. They were able to embody that big, strong back. And when they did, what we found is during that lifting task, relative to those other conditions, they first of all had significantly less pain, they had less fear, but had higher perceptions of strength and confidence. And what I find interesting about this is the extent to which we take meaning from visual information about our own body. So one of the areas that's also very close to my heart, and we've talked about exercises a lot in the couple days of the conference, but as a physiotherapist, as a background, I think the hardest thing is trying to say, I think you should do these exercises, even though I know they're boring, even though I know they're not fun. And I think that's on us, that we're not making them better. And so a real push, I think, of what I've been trying to focus my work on is trying to see if we can find ways where we can actually enhance exercise experiences so that it's not something crappy that people are doing. It's something that actually is enjoyable and that is ways that we can get people moving and get people healthy. And some of, I think, this comes from the knowledge that there's so many people that don't move enough just for regular health. I mean, in Australia, Canada, US, generally only about 50% of people actually meet activity guidelines, so aerobic exercise and strengthening, and it's even less in pain. People with knee osteoarthritis, 9 in 10 do not do sufficient exercise to be able to even maintain heart health. And so this is a real passion for me. And so the ways that I've been exploring this is, first of all, can we just make exercise easier and more pleasant, full stop? But also, can we potentially use different technologies and perceptual pushing of boundaries to bypass or target known barriers to exercise? Or could we actually just make them hurt less before they exercise by using some of these different methods? So I want to start talking about this first one here. And to talk about this one, we got to nerd out a little bit, so I hope that's okay. And it requires going a little bit into perceptual theory. And a very, very basic discussion of this, it's this idea that we have noisy sensory information about our body. There's so much of it. If we actually paid attention to all the sensory information coming in, you'd almost be paralyzed. You can't move, you can't process. And what's interesting is that we block sensory input all the time. You don't necessarily feel your clothes unless you have a scratchy tag, a judgy waistband, or, I've cued you to this. And you're aware of this now. You'll feel your clothes. But you have all this information, sensory input coming in, and to make sense of this, we use our past experience and our expectations. And together, it's thought that these are work together to create this emergence of a perceptual experience. And we call these past experience and expectation priors. And I want to just, before I go forward, I just want to give you a little bit of an understanding of the power of priors. I'm going to show you a video, and basically what it is you're going to hear different sounds. There's different phrases written. I want you to just read those phrases to yourself and just listen to what you hear.
That is embarrassing! 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 That is embarrassing!
So you can shift the phrase you hear with what you're reading. Isn't that amazing? I can't get lobsters in motion. Did anyone get that? Oh, of course you did, Chris. Good man. But what's incredible about this, isn't it, is that you're priming your brain to sort of expect a certain acoustic pattern. And when you get this kind of weird, you got an accent in this, and they're singing away, you kind of sample the different information that you're expecting. So you hear what you're reading. And it's powerful. It shapes what you experience. And so what's really interesting is when we think about things like exercise, we can also have very powerful priors. So if we look at the exercise experience in general, we know that there's a lot of different information coming in. So you have a lot of interoceptive input coming from your own body. You have information from your muscles, from proprioceptors, from nociceptors, potentially, if you're working really hard. You've got information from baroreceptors in your heart, blood vessels. You've got information from your lungs in different capacities. I almost re-felt pain there. That was running up steps near my mom's house, and it's very steep, and it's a little bit triggering. But all of this, basically, you're getting all this information that's giving you input about how hard you're working. And you also then have exteroceptive sensory input that's coming in from vision, from various different sources. But particularly for exercise, this exteroceptive input often shapes what we might expect. So if you think about it, think about the prior of a very steep hill and you're needing to run up it. We know what we would expect, wouldn't we? that should be harder if I'm going up that hill. I will expect that to occur because I've also have these cognitive features that I've done this in the past. I've gone up hills and it's difficult. And maybe I also remember in code how good or bad I felt while I was going up and down hills. And all of these things then shape our exercise experience. So what we were wondering is, could we use a bit of perceptual trickery to actually take advantage of some of these priors that we have and make exercise feel a little bit easier? And so this is work that I'm going to share where it's a virtual reality bike that we created. This is Brendan Mowat, who is now a Ph.D. student, but also at this time was a master's student doing this work. And we were looking at what role deceptive visual cues might play in how we feel while we exercise. So particularly what we were doing was really messing with exteroceptive input. We were messing with vision and seeing if we gave people a perceptual error, so to speak, prediction error about the environment. So this is what the bike looks like. So as you cycle, you basically move through the environment. It is slightly weird because you don't have hands, but actually the bike isn't that high when you normally do it. It's just a bit of a misnomer there. But so as you're cycling, it moves based on how hard you're working. So you have hills, you've got up, you've got down, flat surfaces. So what we did in our experiment is we actually held people's cadence, how fast they were cycling, and the resistance constant. So that is a little marker there. You can see the 70. They just had to keep their cadence within that little green zone. But by doing this, what we're trying to do is we're trying to standardize actual physical effort. So you're always working at the same amount. But then what we did is we put them in different environments where sometimes they saw a flat surface, so that makes sense, that matches with their effort, but sometimes they saw hills. And here, you're seeing a hill, for example, going up, but it's not getting harder. And you get this weird perceptual experience that you're being lifted or dragged up the hill. So what we tested, this is, I'll talk you through these graphs, this is time. This is just 4 different blocks of time that people were exercising. And we looked at whether this differed between flat, downhill, uphill conditions. This is the flat condition, that's our one we're gonna compare to, based on the 2 different conditions, but also how well they could detect their own heart rate, because we thought their interoceptive accuracy might also be important. So here, what we can see is that actually when you show people a downhill, downward-facing slope, and it doesn't get easier, people feel worse. If you show people an uphill slope and it doesn't get harder, they feel about the same, or some people felt a bit better. But there was actually no effect here of interoceptive accuracy. Regardless of how well you could detect your own heart rate, you shift in the same way. So my very scientific summary, fake downhill, bad. Fake uphill, good, maybe, not that much. So easier to make people feel worse, unfortunately. But then what we did is we looked at their ratings of perceived exertion, how hard they felt that they were working. And here we found a relationship with interoceptive accuracy. So it mattered how good you were at detecting your own heart rate. This is the flat. And what we found is that when we show people a downhill, so you're expecting it to get easier, but it doesn't. If you have higher levels of interoceptive accuracy, you feel that you're working harder, even though it's the same physical effort. But if you have lower levels, you're not as good at detecting your own heart rate. Actually, you feel a bit better. Or sorry, rather, you feel that you're working less hard. So opposite direction of findings. If you have an uphill and you're expecting it to get harder, but it doesn't, for people that have higher levels of interoceptive accuracy, they're about the same. They don't change. It doesn't matter between that and flat. But if you have lower levels of interoceptive accuracy, then it shifts a lot. You feel like you're working way less hard. So again, very scientific summary. Fake downhill, bad. If you have high interoceptive accuracy, fake uphill, doesn't really help. Low levels of interoceptive accuracy, fake downhill, good. Fake uphill, really good. So what this suggests, indeed, is that if we give you incongruent input, if we manipulate vision of what you're seeing while you're exercising, it seems that we can take advantage of these priors, these things that you learn about hills, and it can modulate what you feel during exercise. Unfortunately, it's easier to make people feel bad than good, But if you have not as good interoceptive accuracy, it also appears that we can shift this more and in a more positive direction for you. And this might have relevance because actually in many different pain conditions, we often see that, well, people are very aware of information coming from their body. It's not always precise or accurate, meaning that it might be, for those people, this might be the exact thing that might help. And one of my big, I think, I'm going to call them bugbears, is that the hardest thing is for us, we do this in the lab setting, but who cares if we can't take it to the clinic? And that's really been a push with some of the work that we've been doing, where this is led by my students, Erin McIntyre, and then postdoc Dr. Jim Saradakis, and funded by Hospital Research Foundation, really trying to say, that's great that we see some of these things. This has to get to the clinic. So we've been undertaking co-design work with patients as well as physiotherapists to refine and get these technologies to the clinic. And so we've gone through this different process with the virtual reality bike and now have started to test the prototype of it. So this is just data showing you where we had a within-person design, so everyone received either virtual reality cycling or no virtual reality cycling. We didn't mess with hills this time, that got a bit hard. So all we did here is we manipulated the speed that you see the environment go by. So at a certain point, you can kind of notice that you're going faster than you think you should based on how you're pedaling, but it's not enough to feel wrong. And we basically, there's been some studies that have looked at the speed at which that is. It's about 1.21 to be exact. But if you use this, you won't pick it up as wrong. So we used this enhanced speed of cycling while we were doing this. And all we told people was, you can cycle for up to 30 minutes. You decide how hard you go and you decide how long you'd like to cycle. So we had 25 different knee osteoarthritis participants do this. And what we found was this, is that when they were cycling using VR, first of all, they cycled for significantly longer than when they didn't. So it suggests, oh, this is great, they're engaging more. But not only that, so they're cycling for longer, but they worked harder, and they found this more enjoyable. So, which is lovely. If you're gonna work harder, cycle for longer and be happier, I'm happy as a physiotherapist. I'm jumping. And very nice, we didn't see any, no differences on pain during this, so we didn't see flares on pain if they were working harder. How hard they felt they were working in terms of the Borg scale was about the same, but they did have higher positive affect, so they felt better when they were doing virtual reality. And overall, had really nice feedback in terms of credibility of this as a potential intervention and positive attitudes towards virtual reality. So this process, now we're just basically testing this in a prolonged feasibility study where we're actually looking at what happens with virtual reality cycling over a longer period of time. Do we see positive clinical benefit? The second area that I want to talk a little bit about is also whether we can use, as I mentioned, technology to actually bypass or target some of the barriers to exercise. And in particular, we've been looking at whether or not we might be able to use VR gamification for people that are fearful of movement. Is it possible that instead of pushing them to get into those feared postures, can we actually just get them engaging in those activities while they're doing something that is enjoyable? And this is led, again, by Erin McIntyre and a previous student of mine, Maya Sigerseth. Here we did a single subject experimental design, meaning that we took daily measures from people, but we randomized the point at which the intervention started. So everyone starts the intervention at a different time. Everyone underwent anywhere between 6 to 9 virtual reality training sessions, and this was 2 to 3 times per week for about 30 minutes each. And we basically had them do 3 different games. One, Hollow Ball, Hollow Dance, and then a bespoke program that we created called Robo. And we purposely chose different programs, the first 2 on the top, because they are readily available, so that it has that possibility of being used. This is an example of Hollow Ball. Basically, in most of these different games, what you're doing is sort of hitting something. You're using the controllers to hit, it goes out, bounces back, and then you have to connect as it comes back to you. Get this one going. So what you'll see in this one is you hit it out, it hits a target, and then you have to smash it with your controller. And how this works then to promote different movement is, first of all, it's just engaging in movement in that space. But then what also can happen is that depending on where that target goes, it can either promote more back flexion. So in that case, you're seeing it's very high up. So we had 3 different levels in all of these different games. An easy level where the targets were quite high, medium a bit lower, hard a little bit lower, requiring more back or trunk flexion. And so what we found is that it reduced their back pain when they did this. So when we looked at the overall statistics, it reduced their average pain intensity by about 1 point on a 11-point scale. And this is just the individual participant data. And what was quite interesting is that we saw a dosage effect. So if you had higher numbers of VR sessions, you had more pain reduction. So these were the people that had 8 or 9 sessions. So quite positive to suggest that actually this intervention might have value. And we also saw reduced pain catastrophizing in participants. So suggesting that maybe we don't have to worry about really boring exercises. Maybe we can actually make this fun and get people engaged. Another, I guess, area that I've been really interested in as well is whether or not we might be able to use virtual reality and the fact that you're taking on a new virtual body to help out in some of the conditions where everything's really irritable, where everything just flares no matter what. And here, I want to talk about a case study. This is some work that I've done with Dan Harvey, beautiful Dan Harvey, doing with a person with complex regional pain syndrome. And this is a fellow who, he's 43 years old, and he had 3 years of neuropathic hand pain after he had a pocket knife accident where he basically severed a bunch of different tendons in his thumb. And he had multiple repair surgeries. And for him, he had very severe pain that was triggered. Slight touch, movement, cold, observing knife use, all of these things triggered a lot of pain. He tried graded motor imagery. He tried a lot of different, pretty much every single possibility, and nothing was helping because it just triggered his pain and flared. And so we were wondering, well, what if we take him out of the real world and we put him into virtual reality where now what he's seeing is not necessarily, he's of course a representation of his own body, but not his actual body. Is it possible that that might be a nice first step for him? And so what we did is we used technology so that he didn't have to hold controllers. So it just tracked his hands because that would have been a very difficult thing for him. But what we had him do is we had him engage in various different things. Where that's going to go. So that he was basically taking his virtual hand and his real hand in real life and moving it and interacting with different things in the virtual reality. And we actually ended up creating a scale to assess how irritable he was because even interacting with the virtual environment actually evoked pain for him. So we had him undergo 4 different levels, and this is Dan showing you. He's holding the controls, but the participant wasn't. And so he would take his hand and he would place the hand that has CRPS and place it under running water, and that was level 1. Level 2 was, it amped it up. So now you're putting it under a waterfall. So obviously a lot more pressure of this water. And again, we chose these because they're readily available and they're free. And then the next level was because he didn't like cold and had troubles with cold, he put his hand in a snowman. This is actually coming full circle from the magician last night, isn't it? 2 nights ago. Snowman. And then level 4, this was a crazy one, and Dan is very brave, and I don't know if I'd have done this, but he has a poker that he pokes his hand in the area that's sore. So what he did is he underwent a 12-week program where he was interacting using a program called Vacation Simulator and just interacting with the environment. So, and we told him, start with your hand that's not affected. Slowly but surely bring in your affected hand. And then what we did is we measured this evoked pain pre and post that intervention. So at baseline, that first level of just putting his hand underneath, basically what happened is he had this no time at all. It took 0 seconds for the pain to come on, and it was high, 8 out of 10. By 3 weeks, that had reduced to about 21 seconds to come on, still an 8 out of 10. But by the end of the 12-week program, we only measured for a little over a minute, but he could keep it under there for about a minute, and he didn't have any pain. So suggesting that irritability, based on visual stimulus, had reduced. For the poker, unsurprisingly, did not want to do this at baseline. 3 weeks, immediately had a pain of about 9.5 out of 10, so a very severe evoked pain. But by 12 weeks, he could actually, maneuver this for about 60 seconds, and before a pain came on that was still quite severe, but about 7 out of 10. And so what was quite interesting is we saw these improvements within the virtual program, but they didn't extend outside. So it suggests that we really need to think about how we take what's going on in virtual reality and make sure that there's a transition to the real world. Now, the last bit that we've really been looking at is, whether we can actually just reduce pain prior to exercise and give people this opportunity to exercise when they're feeling better. And here we've come back to some of the sensory illusions that I showed you before, because this was the effect of just one illusion on people with painful knee osteoarthritis. But what we did find is that if we repeated these illusions, we had enhanced analgesic effect. But not only that, is it lasted for longer. So it lasted from anywhere about 2 to 20 minutes. And so our question is can we use this technology to create an analgesic window for people to exercise in? And so using similar funding as before, we've really worked to try to take this mediated reality to the clinic. Because again, this is a really clunky technology that in its earliest form definitely couldn't have been used in the clinic. And again, you'll notice, I think I probably should have Erin right up next to me because I'm talking about most of her stuff today. But with her work and working, co-designing with people who have painful knee osteoarthritis and with physiotherapists, we've basically gone from a big box system to using, we went to a model where we had, video kind of goggles and used a separate camera. And now we've moved so that it is basically an iPad that just connects to a table. So really, really portable, really easy to use. And this is just some of the early preliminary data of working with people doing this. This is some of the quotes we got, like, oh, really enjoyed the program. The stretch worked really well. I loved this bit. This is so interesting. I have lots of osteophytes in my knee, so it felt like the stretch would be healing because it widens the joint space to give osteophytes room to breathe. How interesting. I love it. Total relaxation, lost all feeling in the knee, felt like it was floating. The stretch was pleasant and relaxing, pleasant in the knee. When I got up, the knee felt less stiff. And this is an example of what this looks like. So she'll go and she'll just grasp the lower leg, and then basically, and it's a little bit slower, but it will give that sense that the knee is stretching out. And so a person is typically laying on the bed, just kind of looking down, or they can do this in standing as well. And this is just some very, very preliminary data of 4 people that have tried this new version, because one of our fears with this is that if it doesn't feel like it's your limb, we don't see effects on this. It's just sort of a neat party trick. But so what we found is that there were only 2 people that had, really any pain at the time of testing. But we had an immediate reduction in knee pain for those that had pain with one illusion, and then a greater effect when we repeated it. So it seemed to be similar to our other data. And then we also found then that 1 in 4 people, just with one illusion, reported increase in ease of movement, and that 3 in 4 reported increased ease of movement after 10 illusions. But of course, this is just very preliminary data, making sure that we might expect that this would work similarly than the other one. So we're currently undertaking testing with a greater sample to see how this goes. But the last bit that I want to discuss is, really trying to increase our understanding of the perceptual interactions within an individual and how that might relate to their behavior. Because if I think about someone, let's say a person who has pain that wants to go hiking and walk up a hill. And when we're thinking about walking up a hill, there's a lot of different things that combine and come together to determine whether or not we can do this. And so part of this is our perception of our own body. Do I have sufficient resources to do this? Can I go up this hill? but also how steep is the hill? How steep do I see it to be? And Peter introduced this idea really lovely earlier on. But also, what's my emotional state? Am I nervous? Am I anxious? What do I feel about going up this hill? And all of these features can interact with each other. So we've sort of been trying to explore these different aspects within individuals to see what role they might play. So if we start off with environmental perception, here we've been looking at visuospatial perception. And if you're interested, we've done a big systematic review on this. It's open access in Peer.J, so you're welcome to take a look at it, but it will summarize a lot of the different things that I'm going to talk about today. But the idea behind, I guess, visuospatial perception and why we might think that it matters based on our body state and who we are as people is that it's thought that our spatial perceptions are scaled in a way that reflects the ability of us. So as an example, this is estimations of hill steepness, and this is just a small hill, a 5-degree hill on the left and a 31-degree hill on the right. And this is before and now after someone does a fatiguing run. So we see the same hill as steeper when we're fatigued, when we do not have as much capacity. Our perceptions of the environment shift. And we do see similar things in pain. So this is people who have pain, the dark squares, and it's showing they're estimating perceived distance. And this is people with lower limb pain showing that relative to people without pain, age and gender match, they estimate the same distance as being further. And what you'll notice here is actually they're more accurate. So we tend to, if we don't have pain, we tend to underestimate distance, which we think is a way to make us engage and move. Interestingly, there is some specificity. So if you have pain somewhere, but it doesn't relate to the activity that you're doing, we don't see these effects on perception. So it does seem to be specific to your ability to do the task. But we also see that emotion as well can play a role. So if you're fearful, you also estimate things differently. So this is people standing at the top of the hill. I seriously would have loved to drive by while this study was going on. They had people either standing on a block or on a very precarious skateboard at the top of the hill that you could potentially zoom down. And basically just showed that when you're fearful, you estimate that same hill as steeper. And that's protective. That makes sense. These are adaptive shifts. But what we're really interested in is do these altered perceptions potentially also influence behavior? And so this, again, is work led by Erin McIntyre, where we were looking at visuospatial perception in people with painful knee osteoarthritis. And she created 3 different virtual reality tasks that allowed people to estimate the environment around them. And basically what she found is that the people with painful knee osteoarthritis, they're the blue shaded bars. They tended to overestimate uphill steepness relative to healthy controls. We all overestimate hill steepness. We're really shockingly bad at this, but we see that this is magnified in people with painful knee osteoarthritis. And same thing with downhill steepness estimation. So they perceive, relative to age and gender matched controls, the same downhill as steeper. And there's strongly associated with their state fear. So the descending slopes are estimated as steeper the more fearful you are of potentially going down those slopes. But what we also did is we looked at, do any of these things relate to people's physical activity in the real world? So we did objectively measured physical activity and looked at some of these features. And particularly, we looked at a measure called distance on hill. And this really, it's a type of perceptual bias where if you estimate the same distance on a hill versus on a flat surface, you estimate that distance as further on a hill. And it's thought that this is a function of the energetic cost that is associated with actually doing that distance on a hill. And we found here that actually greater visuospatial overestimation, so if you had a greater distance on hill effect, that was associated with lower physical activity levels. Now this is small. I honestly wouldn't expect it to be that big because physical activity is a complex thing. There's motivation, there's a lot of different things that would contribute to this. But it suggests that some of these things may hold relevance. And so for me, maybe some of the clinical ramifications that I think about this is, first of all, people aren't aware that their perceptions of the environment are potentially altered. And when we're working and dealing and trying to, develop exercise programs in people who come to us with chronic pain, their judgments about their capacity to do a given activity are not just about necessarily their body. It might be about how they're viewing that environment, that difficulty of the task. It raises the possibility that there might be a therapeutic role for feedback of perceptual estimations. So there's some evidence to suggest that if you give feedback, you can shift and normalize overestimations of perceptual difficulty. But whether or not that has a causative role, we don't know. And it also just raises the possibility is, to what extent are these stable within an individual? How much do they shift within an individual? And if they shift a lot, if they're actually maybe quite variable, is it actually really hard to learn about safety and danger if your perceptions of what's around you are always shifting? Anne Mulder's does beautiful work showing that actually your proprioceptive accuracy matters to your ability to learn safety and danger, but maybe so does your perceptual accuracy of the environment around you. And of course, we also know that emotional state plays a very huge role. And we are exploring this with a clinical trial that we're doing at the moment, where what we're really asking is if we increase people's knowledge about osteoarthritis, their knowledge about pain, their knowledge about the importance and safety of movement, does that alter their environmental perception? And does then that also positively impact physical activity levels? So we're running that as a formal mediation analyses, and that's just the protocol if you're interested at all. But final data collection is in May, so very excited. But what we're also doing, and Felicity referred to this in her talk, is trying to see if there's actually also some implicit associations between threat and activity. So people might report that they are fearful of a certain activity, but they also might not report that they are. And because that can be a very vulnerable thing to share. If you're saying, actually, I'm really fearful about this, that's not always something that is forthcoming. And so we're interested to see, actually, are there other processes in place that might be influencing this? So this is work from Brian Pulling, where, as Felicity showed in her slides, he uses this implicit association task where you categorize different things into, like images such as this one is rest, into different categories. And it's thought that the speed at which you categorize things, you're faster when it agrees with what you believe, and you're slower when there's something that doesn't match. So if I think that rest is safe, I'm quicker to put pictures into that category, whereas you'd be slower if it said rest and danger. And so we tested this in a lot of people. I think it's over 200 people with painful knee osteoarthritis. And what we found is that they did have, using this test, these heightened threat activity associations. So people in the purple, that's people with knee pain. And then we had a non-knee pain, so a general lower limb pain control, but they didn't have osteoarthritis. We had a no pain control and a no pain age match control. And in all cases, people with painful knee osteoarthritis had heightened threat activity associations. And what's kind of interesting is that didn't necessarily, had very small correlations with their explicit ratings of fear of doing different activities. So to me, this is kind of cool because it suggests that we might be capturing something unique here that can help us, individualize potentially to the person in front of us, but to understand a little bit more globally what might be influencing activity. So we're currently testing this in an independent sample of about 100 people with painful knee osteoarthritis to understand if this has any relation to activity or behavior in the real world through objective physical activity. Now, the very last thing that I want to speak to you about is this aspect of bodily perception that always has my heart. Because I think there's way more nuance to this than we think. Yes, of course, it's that explicit judgment of, can I do this? And of course, that self-efficacy and being able to do things is so important. But I'm so interested in what is behind the scenes of creating that aspect of self-efficacy and the fact that I think I can do this. And why I think I care about this is that how we perceive our own bodies, it can also matter to how we perceive the environment around us. So this is a cool study where they were looking at people where they were taking on different avatars, either a body of a child in the top or a body of an adult. And what they were getting people to do is estimate size of objects in that virtual environment. And they found that if you took on that avatar, so if it moved with you, you felt like that was your own body. When you take on the body of a child, you see the world differently. You perceive objects as bigger. And that doesn't occur if you don't embody that body of a child. But it suggests that we view the environment based on how we feel ourselves to be. And using this idea, we've explored this by trying to understand this idea of perceptual dysfunction or impairment in people that have painful knee osteoarthritis. This is the Fremantle Knee Awareness Questionnaire. And this is work with Ben Wand and Tomohiko Nishigami. And basically it asks questions that don't need to read that. I'll read out some of them for you. But this idea that, my knee doesn't really feel like it's part of my body. I really have to pay attention to my knee to know how it's moving. It feels like it's bigger or swollen. It doesn't feel right. This aspect of hard to move, difficult to know where it's located in space, and that it just feels wrong to you. And so we've been exploring this in people with painful knee osteoarthritis, and indeed have found that they do have perceptual dysfunction in relation to the knee, in terms of it's very hard to know, difficult to know how it's moving, and this is relative to age and sex-matched pain-free controls. But why we might care about this as well, though, is that it's associated with worse clinical outcomes. So higher levels of perceptual dysfunction, more pain during movement, higher levels of disability, higher levels of catastrophizing, more pain-related fear of movement, and more higher levels of anxiety. So clinically, this seems to be quite an affected population, so one that we really want to work with and understand more. Interestingly, though, so we took this data, this explicit sort of ratings of perceptual dysfunction, and looked at whether this relates to environmental perception or physical activity levels, and it doesn't. Doesn't relate to everything unless we take a really huge sample and then the one thing came out, but that's probably spurious based on how many correlations have been done. So this is interesting, so it might not relate to these different things in terms of physical activity or our perception of the environment. But what it seems to do, though, is it predicts response to exercise. So this is 150 people with painful knee osteoarthritis who underwent 3 months of physiotherapy treatment in terms aerobic and strengthening exercises. And people that have these high levels of body perceptual dysfunction using that questionnaire, this is showing we defined responders as people that had 50% improvement in pain. 80% of people that have this high perceptual dysfunction, they don't respond to this exercise intervention. We also see less response in people that have more severe structural osteoarthritis, which is what we might expect. But it does suggest that actually how this knee feels to you might matter. And intriguingly, then what we see is when we look at people who undergo total knee replacement surgery, this is following people over time, and the red line on the top is showing people that develop persistent post-surgical pain. And basically what we see is that very early on, well, their baseline scores of perceptual dysfunction don't predict post-surgical pain. We see early differences as early as 1 month in people that have this persistent post-surgical pain. They don't get these improvements in perceptual function. It's like we've got one group that takes on this knee as their own and one group that doesn't. And our hypothesis is that, well, maybe in this group that doesn't, maybe what we might need to do is target body perceptual function before we're getting them to undertake exercise. Maybe rehab isn't taking. And so for me, I guess the clinical implications is that targeting altered body perception prior to undertaking exercise in some people might hold merit. And Aidan later today is going to talk a little bit about a graded sensory motor intervention that we've done in people with back pain that I think starts to give a little bit of evidence that this might be relevant. But the clinical implications for me as well are that, perceptual trickery, it actually might help our treatments work better when sensory precision is poor, when we have people that aren't very aware of where they're being touched or where that body is located. We saw that in the strong back. We saw that in people using the VR bike. We could make people that are very poor at having very poor interoceptive accuracy. They were the ones that felt better with that VR bike. And so to me, I guess this just gives us a little bit more information about who we might try some of these treatments with. Now, I think it's one of the things that always comes up when we discuss about this but do these things really matter? Does it, these are tiny shifts, perhaps. Does that really have real world or clinical relevance? And I guess what I wonder is, what if you have a perfect storm? What if you've got a lot of little shifts in a lot of different areas, and together that makes a difference? What if you perceive the environment as harsher, and you have heightened threat activity associations, and you actually have altered decision-making relative to effort, so that you require something to have more of a reward for it to be worth it to undertake effort? And what if you're in a society that there's deeply personal, implicit attitudes about your own capacity? Felicity brought up this idea of the rampant ageism that exists in an osteoarthritis population. What happens when we have all of those different things together? This is like a quote that kind of breaks my heart, but on a scan I queried, what's this? What caused this NEOA? My doctor just pointed to my date of birth. Helpful, isn't it? But to me, when we think of this in the context of the larger environment, this is where I think some of these perceptual dysfunctions may hold a big role and play a big part. So to summarize here, I've talked a lot about pain, a lot about dysfunction. Here's my cat. He's beautiful. This is MacGyver. But I hope you take away from this is that, many things that we are entirely unaware of can profoundly shape what we feel. But understanding these behind-the-scene processes really, I think, can have therapeutic merit. Using this perceptual trickery that we're using, maybe we can improve this engagement and enjoyment of exercise experiences. But ultimately, understanding at an individual level the way that these different altered perceptions work and influence and are modulated by emotion, that, I think, helps us understand the people in front of us better. And my question, I suppose, is, are these altered perceptions independent of each other? Are they summative? Or a bit like my cat now that might be a mountain lion, are they exponential? Thank you very much.
All right, everyone. So real quick, if you need a break, please feel free to take one, but we're not going to waste this time with Tasha here. So if you're okay answering questions into the break. Okay, we have some stuff in the back of the room.
Thanks, Tasha. Working with Brendan Mowat, I think that was the best way of pronouncing Moat. I'll let him know. But wondering for post the intervention, how the clinicians then contextualized it to non-VR life with the kind of gains during session, like in terms of reflections and takeaways and the implications of what they gathered from that VR session into their home life or, yeah.
Yeah, sure. So I think if I think particularly about the complex regional pain syndrome one, so what we purposely tried to do was within this vacation simulator program is have it so that it was sort of like kind of everyday life activities. Like it was like you're in a kitchen, you're doing all these different things, you can do that. But I think what we actually do need to do is ensure that as part of that intervention, then what we're doing is practicing some of those same things as part of almost like graded activity with an extension after VR. One thing we've been really interested in, I guess, exploring as well with our virtual reality bike is so we're testing this increased speed, is we want to ensure that what we're also not doing is making it so that then they go and they bike in real life and they're like, wow, this extra sucks. So we sort of have this idea of like tapering that off so that when people are starting, you're trying to make it as enjoyable and pleasurable as possible to almost get them over that hump of like difficulty and getting going when everything kind of hurts a fair bit and not enjoyable, but then starting to titrate back to normal, to reality. But I think it's truthfully, it's not an area that's been studied very much, because I think just the fact that only recently have a lot of these different technologies actually been affordable and able to get into those type of settings. So I think we actually need to do a lot of work to really understand. But I guess one of the things that I do love about this is understanding of some of those mechanisms a little bit more, because there is something about when you're in that environment, time is different. And that is a really, really interesting thing to me in terms of, first of all, like we saw the perceptions of exercise, but I just think generally as well. And so I wonder, I mean, we see like positive aspects of like some of the meditation or breathing programs in virtual reality. So I don't know, I think there's aspects to this that could be really interesting to follow up. Thank you.
Question here, with the back overlay situation, you mentioned immediate responses as far as decreases in fear and pain and increases in confidence. But you also mentioned using 2-point discrimination skills. Did you see quick changes with that as well, as far as like their internal perceptions of self and being able to discriminate sensory?
Oh, great question. So for that study, we didn't test pre-post changes in 2-point discrimination, but there is some work that I think also led by Patrick Haggard and Matthew Longo that was showing that when you're changing the size of the body part, you get concurrent improvements in tactile acuity. So there is some suggestion that these visually held representations also have, I guess, tactile consequences in terms of acuity. But it'd be really interesting, I think, to evaluate and test some of this within clinical populations as well. Thank you.
Thank you, Tasha. That was fantastic. I just one question is to clarify. So you said when people have lower interoceptive and exteroceptive accuracy, they show greater improvement, for example, in the bicycle exercise with the uphill and downhill?
Yeah,
Is
that's
that
right. So it's, interoceptive accuracy. And we just did a heartbeat detection test. Yeah, the Chandri protocol. So it's quite basic, and there definitely is drawbacks of that task, but we kind of also chose it because it is one that you can just use quite easily. So it's like you're randomizing, I think you do like 3 different, like 45, 50 or 60 something, 3 different sections of time, and just get people to count their own heart rate, and then you're measuring it as well. We used an EEG, but you can also use some of the one like just regular technologies as well.
So that's interesting that if you have less accuracy, then you sense greater ease.
Yeah, so what our hypothesis for this is that when you have less accuracy or less certainty about your own internal body signals, you're more likely to be influenced by exteroceptive input like vision, because you're not almost able to rely as much on your own signals because they're maybe noisy or not accurate. And so we see that in, I think Manos Securis has done some work where showing that people that have lower levels of interoceptive accuracy, they experience greater illusory strength, so with rubber hand illusion, things like that. So it suggests that maybe we might be more likely to weight exteroceptive information as higher. So almost some of like the perceptual graphs, we always look at like precision of different information. And if something isn't as precise, potentially, it holds less weight in able to shift, in the ability to shift perception.
And you mentioned this perfect storm of low proprioception, low interoceptive and exteroceptive awareness, spatial awareness, and these other things. Could we infer that if you improve all those things with virtual reality or with some other method, then you're also going to improve pain?
Yeah, look, I think we don't know. So some of our work would suggest that when we're using different bodily illusions to change how you view and perceive your own body, we do have the evidence that that might reduce pain. For me, I almost am picturing this as like, if we have all these different things going on, is it less, I feel like there's always this aspect of like, oh, people don't want to do their exercises because they're not motivated, and it puts the blame on the person, and I hate that. And what I wonder though with some of these different aspects is, are there things going on behind the scenes that actually are making it more likely that the adaptive, maybe we'd argue it might be maladaptive, but that adaptive aspect for your body, for you right now, is to not engage, to not do something, and understanding if some of those processes actually might be overprotective. So if maybe we get to a certain point, and I think they are adaptive acutely, but I wonder if some of those things become potentially overprotective, meaning then that there's actually barriers to moving that are completely outside of our awareness, but that, yeah, maybe if we target some of these, they might be that extra help to get people on their way.
Okay, thank you. So we're going to take one more question. Again, we're going to start the next talk in 10 minutes. So if you need a break, please take one. But here's our last question.
Thank you. That's so interesting. I had similar questions as to what was posed just a moment ago. And I'm actually even wondering, right, intuitively it would seem that having more accurate interoception is a good thing. Perhaps we can use this more like a diagnostic assessment, and as more information for the patient to say precisely that, your system is overprotective, right? I don't know that that's something that you could investigate on, but that would be interesting.
Yeah, I think for me, it's probably like an interesting conversation to, some of these measures, I guess I would view them as a way to broach a conversation about the different changes that can occur when we have pain, and then the potential relevance of why we think different interventions might be helpful. It is interesting because I think when we look at different things like interoceptive accuracy, it's, even within our study, it's a relative thing. So there's not necessarily one level that we can be like, oh, if you are this, it's poor, or we don't sort of have those different levels because it is quite individually specific. But I think what would be really interesting to look at is to see, indeed, are there different aspects that that seem to matter clinically in terms of how you present on those different tests. There certainly is a little bit of evidence to show that if you use different feedback methods to train interoceptive accuracy, people can improve it. But I think also some of these things, I wonder, to what extent are some of these aspects pre-existing? And it's just who we are as people that might make us more prone to have different things within our life, and to what extent are these caused by once we have pain, and we don't know the answer to that, because I think there are some aspects is that, like, we all know people that have never been very coordinated, or people that are really coordinated. Like, we all have differing aspects on that, and to me, I guess I'm really interested to know, to what extent is something potentially there and impeding your ability to be part of rehabilitation or exercise or something, versus something that is there and is actively contributing to the experience of pain. And I think bodily perception, to me, I think could be both, but I don't think we know.
All right, thank you. Let's have another round of applause. And then again,